We'll be able to finish on time. Our first speaker, Mehta. Jaw's probably getting sore given all the talks that he has at this conference. Coming to us obviously from Singapore National Eye Center. He's going to be starting off this session with a talk entitled DALK in 2024.
Great, thank you, Tony. So thanks for the invitation to talk in this session. So I'm going to be talking about the way we do DALK now in 2024. So these are my disclosures really pertaining to CIMA, which we'll basically be talking about in a bit more detail. So lamellar surgery has become the gold standard in surgery across the world, really, for EK replacement with DMEC or DSEC, and for anterior lamellar capacity, basically with DALK. But the rates of DALK vary around the world, as you can see from data from EBA at the top, and data from Singapore Corneal Transplant Database below as well. And in Singapore, about 30% of all my cases are basically done with DALK. And really, to increase the rates of DALK worldwide, we need to basically de-skill the procedure. So a few years back, people talked about using a femtosecond laser for the procedure, and you can have all these fancy cuts around the edge of the side cut angle for the laser, and it's been shown to sort of give you better wound strength and allow you to take your sutures out early. But interestingly, in the longer term, once the suture is actually all removed, despite the fact you get better apposition and alignment, actually the astigmatism results actually come back to being very quite similar to what you see from normal full thickness or partial thickness transplantation. And the problem with all these publications that you see where we use femtosecond laser assisted keratoplasty is that following the rim cut, you still have to make a tunnel to insert the cannula to get the big bubble. So it kind of makes it nice that you get a nice incision with the apposition, but it doesn't help you basically to get the big bubble, which is probably the ultimate goal for most of us when we're basically doing DALK surgery. So a few years back, we're using the Z8 femtosecond laser, which is a low energy nanojoule laser system. We developed a program with Zima in order to make the tunnel intraoperatively at the same time that you basically do the DALK procedure. And this was using the intraoperative OCT. This just basically shows you how this basically works. On the left-hand side is some animal eyes that we basically did. On the right-hand side is a human donor study. And we optimized the system basically on pig eyes with respect to the lamellar cut and also basically the tunnel cut. And then we basically tried this on human donor eyes to basically show that we could get the bubble. And when you look at the histology and basically also on the OCT, you can see you get a nice big bubble basically in these corneal samples in these human cadaver eyes. We then went on to do a series in collaboration with Theo Seiler in Europe. And these are basically some of the first cases that were published back in 2019. So we did about 14 cases, a mixture of pathologies, mainly keratoconus, a few scars. And so you can see on the video the intraoperative OCT now coming up into alignment. And this allows you to set the tunnel depth exactly between about 50 to 80 microns away from Descemet's membrane. So you get a very good accuracy. Now, this is done with the flat applanating system on the Z8 currently. So that's why you see those posterior folds in Descemet's membrane itself when you're basically doing the surgery. But once you basically done the applanation, you then basically fire the laser. It does the tunnel cut first, and then it does the side cut basically onto the surface. So you can see it basically occurring now. So once it's fired the tunnel, it'll then basically do the vertical rim cut all the way across basically up to the surface. So it does the lamellar patch, and then basically all the way basically up to the surface to the epithelium. And then you can cut the donor tissue either with a standard Trefine or basically with a the femtosecond laser as well, whichever you basically want to do. So then all you have to do is basically peel off the anterior lamella. It's often slightly sticky where basically there's a scar, and then you'll see there's a track there. So the track, you basically put your DALK cannula into itself, and then basically you inject, and then you hopefully will get a big bubble. There you go. Okay, so you get a bubble basically formed. So in the series of about 14 cases from the first publication with this tunnel, we had about 3 cases of basically rupture during the dissection, ironically not during the bubble formation, and these were all successfully completed itself. So following our publication, there were 2 other papers, one using the Victus femtosecond laser. We're giving you a straight edge cut, and they were able to get a big bubble in 100% of their cases in a small series, I think about 15 to 18 cases. And Boris published a series from Russia, basically showing that by using the intraoperative tunnel guidance, he was able to improve his success rate of big bubble formation from 36% to basically 65%, but also importantly reduces the conversion rate to penetrating keratoplasty from 15% down to basically 7%. But we also know from the literature that actually if we could change the shape profile of the graft from a straight cut to a mushroom cut, this would also be advantageous because basically we can improve the refractive outcome basically from our patients. But the tricky thing is that how do you combine both of these technologies together? So i.e. a mushroom and basically the sort of disruptive technology, which is basically the tunnel cut on the same side as well. So we thought this was basically an important thing to try, so we tried to basically do this with laser. So the laser has to move twice now in order to basically get this cut basically trephined itself. And we know the importance of basically of doing this because it allows you to suture your graft well away from desmoid membrane. And we know from our publication that basically 27% of all perforations or microperforations occur during basically the suturing. So we went back to the wet lab again with some pig eyes back in 2022, and we came up with a software basically in order to basically do this on the Z8 femtosecond laser. This is the first patient that underwent the surgery, 53-year-old Chinese lady who had cross-linking on her right eye, left eye contact lens intolerant. You can see basically for 16 diopters of irregular astigmatism on the corneal surface, and she underwent a left mushroom DALK. This laser itself is basically docked onto the surface, similar to basically what I showed you, but now the laser head's going to move twice in order to basically get the mushroom cut. So the intraoperative OCT allows you to set basically the end of the tunnel to 50 microns away, which is what I do for all my cases now, away from desmoid membrane, and you can change basically the angulation of basically the tunnel depth itself. So I do use a 400 micron width tunnel, well not 600, which is what Zima recommended initially, and this seems to give you the optimal profile with respect to getting a big bubble. So now it's doing the lamellar cut, which is typically about 200 microns away from desmoid membrane, so 150 microns away from the tunnel, and now we're basically going to do the side cut around the whole thing. The whole thing takes about 35 to 40 seconds to do the laser cut, but it does take a little bit of time to do the program, which you can do basically before the surgery itself. So once the basic laser is cut on the surface, you simply just basically peel off the surface from the edge. So there you go, so you peel off the surface from the edge, and then you've got your hole there on the surface. This is I open it up with a Sinskey hook. So this is my tunnel hole. You simply just put your cannula in to that basically hole. So I use the Donald Tan cannula with a hole at the bottom, and you basically inject basically to get the big bubble. There you get the big bubble, and you only have to go out to basically 6.5 millimeters basically from the surface. So this is the result basically. Afterwards you get a nice regular profile on the surface and a very even topography profile, obviously because you've got the mushroom cut. So obviously that's an easy case because it's keratoconus, the cornea is clear, but we've done it for avellino corneal dystrophy, and I've also done it for mucopolysaccharidosis as well, and the laser will basically cut through these corneas very well as well in order to basically get these mushroom cuts. So I'll show you a bit more complicated case. It's a 19-year-old boy where you can see that previous scar on the cornea itself, and he has basically a 76 diopter cone as well. And again with the laser, this shows you the big advantage of having the intraoperative OCT, because you'll see that once we basically applicate the laser onto the surface, you will see, so I'm just showing you the scarring here on the OCT to show you how deep it is. But you can see this on the intraoperative OCT. So what I can do is I can set the edge of my tunnel just before you basically see the scarring depth on the surface there itself. And this allows you to the movement from the tunnel on the OCT to know exactly where the tunnel is basically going to be. So you can see the scar basically on the surface. So once we basically set the depth again, we do very consistent 50 microns away from desmoid membranes, from the folds there. You'll see that they're dropping down the lamellar cut across the surface to keep it about 150 to 200 microns away from desmoids. If you do a keratoconic case, you must do the recipient first and then do the donor. Don't do it the other way around. Okay, so when the laser's firing, you can see it's firing the tunnel. Now it's a horizontal cut, and now it's basically doing the mushroom side, and then basically it's doing the vertical cut on the edge. Then it's basically going to laser up to the surface. And you can imagine when we basically peel off the surface now, obviously where there's a bit of a tag, basically the scar there, you'll have to basically dissect it a little bit. So as you see, I open up the edges first of all, so you gently peel the surface, and it's cut through the scar pretty well, actually. I mean, I'm just basically just gently manipulating that with a Sinskey hook to remove any of the basically remaining tags. So once this is basically released from the surface, then you have your tunnel there, and then you just put your cannula inside the tunnel that's already been basically pre-created basically before. And sometimes people find it difficult to find a tunnel. If you use a Sinskey hook, it'll help you basically open up at the beginning. So once you put your cannula in, it's right at the point just underneath where that scar was, and I was able to predict that from basically the OCT, and then you can see the bubble formation, and the rest of the surgery is basically routine as normal. This is basically the post-op, but this is that 1 month post-op. I've never seen visions as good as this in all the DALK surgery I've done at 1 month post-op with this technique. So conclusion, the use of femtosecond laser in keratoplasty has shown some advantages, but the introduction of intraoperative guided tunnel is really a disruptive technology in the field. The use of mushroom DALK with the tunnel offers the advantage of a tunnel creation optimal profile itself, and DALK in 2024 is mushroom with an intraoperative OCT guided tunnel. Thank you for your attention.
We have time for a question or two from the audience. Do we have any questions for Judd? I have a couple. One is the creation of the tunnel.
Yeah.
What's the width? Because it seems like if you're inserting, what's the gauge cannula you're using, that if
Yeah.
it's too wide, of course, you're going to have just reflux of air and you're not going to get a big
Absolutely.
bubble.
Yeah, that's correct. So initially that's why initially we basically optimized it on the animal. So we use basically 0.4 millimeter, but you can set it to any width of the cannula that you want itself. So with Donald's cannula, basically 0.5 fits absolutely perfectly. So I haven't tried any other cannulas, but you can optimize it to whichever cannula you want. But 0.5 is what 0.4 is what I use on all the cases for the width.
And that leads to the second question I had, which was, and you actually touched on it, is it hard to find the tunnel? Because many times I'll make a track with a dissector, then I go back with my cannula, and I can't find my damn track that I just made with my dissector.
Yeah.
And so if you have such a small tunnel, you mentioned you can use a Sinskey hook to try to identify it if you're having trouble.
So the key advantage is, so with the non-laser cases, the trick there is I always basically use a felt tip pen on the thing to make the track, then you can always pick it. Here with the laser, so I didn't show the Avellino case, but the Avellino case, you look at the sky, you think you can't see it. But actually, it's easy because you know where the tunnel entrance is in relation to the change in your mushroom profile, because you know that from the laser you see, because that's fixed position. So you know that. So basically, using the Sinskey hook basically will help. Someone else told me something that I haven't tried, which they said that if you peel the cornea in the reverse direction from inferior to superior, apparently they said it's maybe a little bit easier. But so far, I have been able to find the tunnels, and using the Sinskey, I think, is quite a nice little thing, just to open up the tip and then put your cannula in.
Very good.
Sorry. Have you tried without doing the bubble? Have you just
the mushroom, yeah.
Just-
I have a case with a hydrops case where I just do the mushroom cut, and basically I just don't do the tunnel. But the advantage is it takes away like the first bit, like half an hour of the surgery, down to like basically 45 seconds. You can just simply bit it back, and then I just do a manual dissection, so I don't do the thing. The downside of this technology currently is that, of course, it's using a flat applanator. That's why you see those curves. So we have a new software now, which is a liquid applanator, hopefully to do exactly the same thing.